Hello, everyone. I think we'll go ahead and get started. I'm going to go over a brief introduction. Yat-e shike do shidane she Corina Sabiku Yanisha Tachini Nishle Hawatlana Bushishteen Tohoglini Dashache Ma Idushkini Dashanele Akot Ego Dene Atane Nishle. This is how I introduce myself as a Navajo woman. Good afternoon, my friends and relatives. My name is Corina Sabiku. I am from the Red Running into the Water clan, born for many Hogans. I am a senior research program coordinator under the Center for Health Equity and Community Engaged Research here at the Mayo Clinic. I want to welcome you all to the Indigenous Health Topics speaker series. For those who are joining for the first time, I'll just give a brief description of what Indigenous Health Topics is. We are focused on hosting speakers who are local, regional, and national experts in health, education, and research. Our presentations will be focused on topics that have an impact on our American Indian, Alaska Native communities, and there will be opportunities to attend in person at our Rochester campus and virtually. I want to thank you all for joining us today to listen and learn. I have just a couple housekeeping items. We will have time at the end of the presentation for Q&A. So feel free to add your questions to the Q&A or chat, and we will get to them at the end of our presentation. With that said, I'd like to welcome and introduce our guest speaker today, Dr. John Molina. He is Yaqui and Yavapai-Apache. He has served on the board of directors for San Carlos Apache Healthcare Corporation and the Pascua Yaqui Healthcare Corporation, and on faculty with the University of Arizona College of Public Health. He served as compliance officer for Native Health Urban Indian Health Center in Phoenix, health systems director for the Kenai-Tsi Indian Tribe of Alaska, CEO for Phoenix Indian Medical Center, and assistant director, medical director for AHCCCS. He practiced as an OBGYN physician with the Indian Health Services and funded Las Fuentes Health Clinic in his hometown of Guadalupe, Arizona, and is a Navy veteran. Dr. Molina graduated from the University of Arizona, Go Wildcats, College of Medicine, and Arizona State University College of Law, and received an honorary Doctor of Humane Letters from A.T. Still University of Health Sciences. He and his wife, Dr. Stephanie Little Hop Big Crow, who is Titwan Lakota Ogallala, have 6 adult children and 9 grandchildren. Please welcome our guest speaker, Dr. John Molina.
Thank you. Good afternoon, everybody. My name is John Molina, and thank you for your time. And I appreciate you all kind of joining in and giving us some of your time to be part of this presentation. And thank you, Corina, for the very kind introduction. I am Pascua Yaqui and Yavapai-Apache. My homeland is in the area of Phoenix, Arizona, where the Yaqui Indians settled before Arizona became a state. But anyway, what I'd like to do is go and share some insights and thoughts about the Indian Health Service. I share this, thought that I would share this today because I know that as Mayo Clinic staff, a lot of you have interactions with Indigenous people, but also perhaps within the Indian Health Service, who's a major healthcare provider for the Indian people of this country. So with that said, I'll just go ahead and get right into the presentation, and hoping that we have time at the end to answer any thoughts, questions, or insights that you might have regarding the Indian Health Service. So with that, I'll just go ahead and share my screen, and we'll do this. I think we can do this. Okay, all righty, I think we're up. Are we good to go, Corina?
Yes, we can see it.
Okay, really good. Again, to today's topic will be the history and role of the Indian Health Service. And again, I thought that I would kind of present this because the Indian Health Service is the major provider for the Indian health, for the indigenous people of this country, and also because it does play a significant role in terms of how it interacts with the non-Indian health facilities of this country, whether they're private or nonprofit corporations. I know the Mayo Clinic does a lot of work with the Indian Health Service as they get a lot of referrals from there. So with that said, I'd like to just go ahead and talk a little bit about what the Indian Health Service is all about. So the next slide, I don't think I can move it to my next slide. Is that moving?
The arrows should work to get you there.
Yep. Yep, it's not moving it.
Try the up and down instead of the sideways arrows.
Nope.
If you right click with your mouse, does that give you an option? Make sure you're clicking into, yeah, let's see. There up says next up at the top. That may get you started.
Oh, there we go. Okay, we'll go ahead and do that.
Now probably the arrows should work. We'll hope.
Yeah, there we go. Excellent, thank you. I appreciate all the technical help here. So to today's presentation, I just want to kind of review some of the objectives that we're going to be talking about. We're going to be talking about the political relationship of Native American tribes to the federal government. I think this is the foundation of healthcare with Native people in this country. It's important to understand that. And to look at the evolution of the Indian Health Service, and we're going to look at the three entities of the Indian Health Service and the way it's sort of centralized and the way it operates across the country. And we're going to look at understanding some of the services and benefits for Native Americans under the Indian Health Service. And we're going to identify four major elements that do contribute to lower health status among Native American people, and understand how a Native American social cultural perception can influence our decision for medical care, for health care, for access to care, and maybe end up understanding some basic elements of caring for the Native American patients. As the quotation down there, I've always believed that education is not the filling of a pail, but the lighting of a fire. As we gain more information, hopefully we are inspired or to get some insight into how we can improve the services that we're doing and the people that we're providing care to. I think it's always important to begin any topic on Indian healthcare, starting from the very beginning. And I do this very respectfully because though this was a dark history in the founding of this country, it kind of helps us give us perspective onto where we're at and where we need to go into the future. After the Revolutionary War, the national policy was land expansion. And unfortunately, the extermination of the inhabitants of this country, or as the government called the Indian. The new colonists imagined expansion, progress, and posterity. But unfortunately, the Indian people experienced decades of violence, eventually the land loss and poverty of the country, of the world that they previously inhabited. One of the major topics in a lot of literature talks about is historical trauma. And this relates to the experience of Indian people during the period of colonizations. There were Indian wars and massacres, a loss of traditional lands, and forced placement on the reservations, which really kind of brought Indian people under an oppressive state. On the right-hand side at the top, we see a photo of the Wounded Knee Massacre, where 150 Indian men, women, and children were killed by the military in what they thought was a uprising. And some of the people in this military photo where they were part of Custer's who didn't attend the Battle of Little Bighorn, but they felt that it was in retaliation for the loss of the battle at the Little Bighorn by Custer. So they put a mass grave and put the bodies in there. That photo at the bottom right is actually a photo there at Pine Ridge Indian Reservation of the monument where the bodies were buried. My wife actually grew up about 3 miles from this massacre site. So this is a history that is pretty common among all Indian people across the country as they encountered the push westward. What also happened was there was a lot of Indian land that was given up for sale, for settlements. And unfortunately, during this process, a lot of the land that Indian people were living on were very familiar to them as lands where they grazed, where they're hunted, and also they had their sacred sites. So they lost a lot of this land as they were moved on reservations. And on the bottom left, you can see a photo of the San Carlos Apache Indian Reservation, where my mother was born and raised, as Indian people were forced to live on reservations and rely on the government for their livelihood, for their food, and for the provisions that they needed to survive. And now, again, this kind of brought Indian people under an oppressive state under the government. Probably the one thing that I think was most impactful to Indian people was the forced schooling of young children, where young children across the country were forcibly taken from their Indian parents to be assimilated into a Western way of life and civilization. The photo on the left lower side is Carlisle Indian School, one of the largest schools where Indian kids as young as 3 years old were taken to assimilate and to speak in English and to not practicing their cultural ways and to cutting their hair. And the policy at that time was, I think, was well coded by Henry Pratt, the founder of Carlisle, who the policy at that time was to kill the Indian and save the man. Here in Phoenix, we had a Phoenix Indian School, a boarding school, which was located in central Phoenix. And that picture on the right shows the kids that were again forced to assimilate to a new way of life and a new religion, which was Christianity. The unfortunate thing is that as a result of this generation began to lose contact with their language, with their culture, with their people. And indeed, when these Indian kids return home after being assimilated, they struggle to relate to their families because they were taught that it was wrong to speak their language and practice their ceremonies. So the impact of this historical trauma sort of is still seen today, to the generational history that is shared in the narratives that are spoken in families about their history, and along with the influence of epigenetics on as a result of the impact of historical trauma, where now we see a lot of cases of mental health, depression, anxiety, hopelessness, social problems related to suicide, drug abuse, poverty, and health conditions, obesity, diabetes, coronary heart disease, and cancers. And these are sort of have related by a lot of writers as being related back also to the impact of historical trauma, which continue to be shadowing today's lifestyle for Indian people. Now, with that said, I think it's important to understand that the government did recognize the sovereignty of Indian people, as they were the first people in this country and this land. So what the government did is entered into over 350 treaties with Indian people across the country. The one photo on the right shows a copy of the treaty with the Potawatomi Nation in 1846. And part of the treaties was at the very bottom was that the government promised to give all proper care and protection to Indian people. And many of these treaties contain language regarding healthcare, regarding provisions for healthcare and providing physicians to Indian people as part of their healthcare. Subsequently, over the years, the United States, through congressional acts, instituted a series of different acts through Congress in order to make good on the treaties, if you will, to provide for buildings, for housing, for environmental safety, and for healthcare through different congressional acts that were recorded and implemented by the Congress of this nation. And I'll talk a little bit more about some of the acts that are substantial to Indian healthcare. So the thing about Indigenous people of this country, they have a sort of special relationship with the government that's kind of noted as a government-to-government relationship with the United States. And this is based on the treaties and the agreements that were made between the government and Indian tribes. And the treaties, a lot of them were made in return for possession of Indian land, as well as to reduce wars between the Indian people and the new people that were settling the land. So from the very beginning, the government has promised, if you will, and also has memorialized a relationship with Indian people, and part of that was healthcare. Throughout the course of my work in the Indian Health Service over the last almost 30 years, I've always heard the statement made that Indians receive free healthcare. And that's really not true. In fact, it's prepaid, if you will, for the giving up of Indian land and resources to the government in return for healthcare. So it was prepaid and certainly was not free for the historical trauma that Indians had to experience, as well as the loss of land and the loss of their culture in the very beginning. So again, it's not free healthcare, but prepaid healthcare, as I like to refer to it too. Now, this is sort of a background in the history of the Indian Health Service. In the very beginning, during the onset of colonizations, a lot of healthcare was provided by people who just cared about Indian people, mostly by missionaries. But again, the missionaries were attempting to Christianize Indian people, so that was part of their work also. In 1824, the healthcare was then under the responsibility of the Department of War. And a lot of those cases was because they were setting up different forts across the country in Indian land. It was part also to protect the military from infectious disease from Indian people. So they offered healthcare to the Indian people so that their own soldiers wouldn't get sick. In 1832, Congress appropriated money for healthcare for Indian people because of the smallpox epidemic. In 1849, healthcare then was passed on to the Department of Interior. And then in 1854, the responsibility for healthcare of Indian people passed on to the Public Health Service under the Department of Health and Human Services. And the year following, the Indian Health Service was then created in 1955, which is the Indian Health Service proper that we now see today. Now, before I talked about some congressional acts that were initiated by Congress, and regarding to healthcare, these three acts are probably the most significant that's related to healthcare. The first one is the Snyder Act that was passed in 1921. And this was the first formal authority under Congress to provide funding for healthcare. And under the language which was in the act itself, it was funds for the relief and distress and conservation of health and for the employment of physicians for Indian tribes. So this was really the first act of Congress that appropriated money for Indian people for their health care. Then in 1975, the Indian Self-Determination Act was passed. The significance of this act is that now the government gave the opportunity for Indian people to become involved, for Indian tribes to become involved in their participation and direction of their programs, not only healthcare, but educational programs, and allowed the Indian tribes to contract with government agencies and the Indian Health Service and receive grants to be able to take over the management of their healthcare. And this has become very significant in Indian country now, as I'll talk about a little bit later, is a lot of Indian tribes are taking over the management of their healthcare facilities and their hospitals. Then in 1976, the year following, the Indian Healthcare Improvement Act was passed and expended the budget of the Indian Health Service to provide healthcare facilities and services and resources to Indian tribes. And a lot of it was to begin to rebuild a lot of the old medical facilities that were in need of new facilities. And this one also allowed to provide grants and funding for Indian people to become healthcare professionals under the Indian Healthcare Improvement Act. And actually, I have to say that when I went to medical school, I was kind of a late bloomer. I got into medical school when I was 34, and I was actually a crisis counselor before med school. But when I decided to go to medical school, I already had a family, and the tuition and every other expenses were probably out of my range to attend medical school. But because of the Indian Healthcare Improvement Act, this public law 94-437, I was able to attend med school as the government paid for my tuition and books in order to be able to go to to med school. Now, the Indian Health Service System is a nationwide system, and it operates under the Department of Health and Human Services. And the Indian Health Service is the primary provider for medical care and public health services to federally recognized native tribes here in the lower U48 and also in Alaska. It provides care, direct care in 37 states, mostly on the western side of the country and in Alaska, to about 2.2 million people, native people out of 303.7 million people. The reason for this is that because Indian Health Service only provides care without cost or without a copay to people who are registered with a federally recognized tribe. And I'll talk about that a little bit later. So as of April 2017, and this number has not changed very much since then, the IHS consists of 26 hospitals, 59 health centers, and 32 health stations across the country. There's also 33 urban Indian health projects or health programs that are located mostly in the metropolitan area. The last place where I was employed at before I retired was Native Health, and it was an urban Indian health center here in Phoenix. And again, many tribes now also operate their own health systems independent of the Indian Health Service. So the Indian Health Service is the primary healthcare system for Native American people. And there's three entities that are involved under the umbrella of the Indian Health Service. There's the Indian Health Service facilities that are federally managed by the government. And then there's Indian Health Service facilities that are managed by tribes. And then there's urban clinics that are operating in major metropolitan areas like Phoenix, Los Angeles, Milwaukee. And so again, just to refresh, is that the federal government's responsibility for healthcare to Indian people has been sort of memorialized by the treaties, by congressional acts, and by federal doctrine, and continues to kind of be very active even to today. So the funds of the Indian Health Service are prepaid obligations between the United States and the tribal nations. The operating budget for 2022 was in the area of $4.3 billion. But unfortunately, even with this amount, the IHS basically averages about 59% of actual healthcare needs. When I was at Phoenix Indian Medical Center as CEO, the operating budget for the Phoenix Indian Medical Center, the IHS provided only 49% of the funding to operate that hospital. The other 51% we had to get through third-party billing through Medicare, Medicaid, and private insurance. So in essence, the Indian Health Service has not really met its trust responsibility to fully fund the Indian Health Service, but relies on the Indian Health Service to bill third-party insurers in order to make up for the difference. That continues to be an area of contention with Indian people because, again, the treaties were the basically law of the land that the government said that they would provide all proper care and protection for Indian people, and the government has not made that obligation. Just as kind of a side note here, there was a Supreme Court the decision in 2020, McGurk versus Oklahoma, that was really mostly land in a territory settlement case in Oklahoma, and where the state was saying that they own certain land, but according to treaties, the Oklahoma tribes own that land. And interesting enough, the U.S. Supreme Court sided with the Indian tribe, saying that treaties are the supreme law of the land, and the government, including states, needs to recognize that. So the land was given back to the Oklahoma tribes because of the treaty. Now, what's interesting about that case is that it now opens the door, if you will, to use that landmark decision by the Supreme Court to say, okay, government, it's stated in treaties that you are going to provide all proper care and protection to Indian people. So under the McGurk holding that the treaties are supreme law of the land and states and government need to recognize that, it might open the door for litigation to hold the government's feet to the fire to provide for complete funding of the Indian Health Service. Now, the Indian Health Service is divided into different areas. And here you can see the breakout. And we are currently in the Phoenix area, here in Phoenix. The Mayo Clinic Scottsdale is located in the Phoenix area. Then we have the California area, the Alaska area. And each of these areas has centralized the director, the kind of an area director that we call him, that oversees all the operations and administration of the different health clinics and hospitals that are located in these different areas. The main office for the Indian Health Service is located in Rockville, Maryland. In fact, we just got news that Rosalind So was just appointed formally as a director of the Indian Health Service, which now oversees all the different healthcare operations throughout the whole country and Alaska. Now, I want to get into a little bit about eligibility and the different types of care that the Indian Health Service provides. First of all, for an Indian person to be eligible for services at an Indian Health Service facility at no cost and no copay, they must be part of an enrolled member of a federally recognized tribe. They also must have some communication and connection to their Indian tribe as another type of eligibility requirement in some cases. Now, non-Indians can also receive care if they are the child of an eligible Indian or the spouse, including same-sex spouses of an eligible Indian, or a non-Indian woman pregnant with an eligible Indian's child. And to apply for benefits for Indian Health Service, usually the person has to enroll themselves in the registration office of the Indian Health Service facilities, and they have to show proof of enrollment in a federally recognized tribe. Currently, there's over 570 federally recognized tribes in the country. 229 of those are in Alaska. So they have to show proof that they're enrolled in a federally recognized tribe in order to receive services at no cost and no copay at an Indian Health Service facility. Now, the Indian Health Service facilities only provide what's called direct care. Direct care means only those services they're eligible to receive that's provided by that facility or the clinic. It could refer to medical care, dental care, behavioral health services, which are provided by the facility, is where they can receive that care. Now, if the care needs to be provided outside of that facility, like say at Mayo Clinic, then it might be they might be eligible for what they call purchase and referred care. In other words, the Indian Health Service gets a certain amount of money to provide for care outside of the Indian Health Service, but that money is limited. It only is used for those cases that's a medical priority and based on funding availability. Unfortunately, in most cases, these healthcare facilities that have this extra funds to provide care outside the Indian Health Service facility, usually by October, November, those funds have run out and they have to wait for the next year in order for the government to add to that fund to provide care outside the Indian Health Service. Here's a photo of a tribal enrollment card from my tribe, the Pascua Yaqui tribe. And again, each tribe has their own enrollment card for their people that they can show that they're enrolled with a Native American tribe. In this one, it's a Pascua Yaqui tribe. It has a Pascua Yaqui emblem, the flag. It's got the identifiers for the person. It's got a photo. It's got the birth date. And it's also got the enrollment number. That number that you see down there, EDN 1AD000211, is the number that actually enrolls this person with the federal government as a bona fide Native American person. And most of us do carry this card with us. If we use this card not only for healthcare, but for any other benefits, maybe education or employment, under the Indian Health Service that can be provided to the person. Now here's where we get into a little bit about how perhaps Mayo Clinic sort of is part of a player, if you will, within the Indian Health Service. First of all, let's kind of look at this family in the center of the photo. So this family is an Indian family, are enrolled with the tribe, and they can actually receive services at any of the three entities of the Indian Health Service, either the Indian Health Service managed facilities, which is the I, or a tribally managed facility, which is the T, or the Urban Indian Clinic, which is the U. Typically in Indian country, we refer to this as the ITU system. So this family and their kids can actually receive services at any of these different places. And a lot of it depends where they live. Again, a lot of our families are very mobile and they move around, quite often. So whether they're in a metropolitan city on the reservation or the visiting families on another reservation, they can actually receive care at no cost and no copay as long as they show their enrollment card at any of these three different types of facilities within the Indian Health Service and provide the direct care that's offered by that facility. Some facilities offer more care type services than others depending on the size, but again, they're able to access those services. Now, unfortunately, what happens is that sometimes maybe it's a medical issue that requires specialty care. In that case, the family or the individual or the family is referred outside of the Indian Health Service system umbrella to outside providers like Mayo Clinic. Now, once they get to the Mayo Clinic, then the Indian Health Service basically doesn't cover that care or payment. The patient has to rely on Medicare or Medicaid or private insurance or in purchase and referred care, as we talked about earlier, to access those limited funds that the Indian Health Service has to pay for that care, or the patient has to do a self-pay. So this is where we kind of get into issues and access to care and services for Indian people, is their ability to pay for services outside of the Indian Health Service umbrella. And this is why it's so important that Indian Health Service gets funded according to the full amounts that were under the trust responsibility of the government, because then with more funding, the Indian Health Services can actually build more facilities, hire more staff to be able to provide that specialty care that's currently not being able to be provided in many of the facilities within the Indian Health Service system. Here's just a couple photos to show you some facilities. At the upper left side is the Phoenix Indian Medical Center, which is the largest federally managed facility in the country. It provides a wide range of specialty care and outpatient care, inpatient care, and the Mayo Clinic Scottsdale has a strong affiliation with this hospital in partnership in providing cancer care. That hospital is federally managed by the Indian Health Service. The photo on the right hand at the top is Native Health. That's the Urban Indian Clinic where I was recently employed as compliance officer. The Native Health is an urban Indian clinic. The urban Indian clinics were actually established in the 1960s and 1970s to provide care in urban areas where there was no Indian Health Service facilities. In the major cities where a lot of Native people were relocating to. In fact, currently, over almost 70% of Indian people now live in urban areas to be able to have access to employment, to education. So these urban Indian clinics are very important, in a big urban areas where we have a big urban Indian population that are there, that have left their home reservation. The photo on the bottom is the San Carlos Apache Healthcare Corporation Hospital. This hospital was built by the Indian Health Service on the reservation in San Carlos here in Arizona, on the San Carlos Apache Indian Reservation. And after it was built under the Self-Determination Act that we talked about, the tribe was able to take over the management of this hospital. So this hospital is now managed by a board of directors from the Indian Health, from San Carlos Apache. They manage and operate this hospital. The benefit of this running the hospital is that it really allows the tribe and the community to manage their own healthcare services in a way that is really reflective of the needs of that community. That has been the strongest point, is that they're more flexibility, both in terms of operations and facilities and services, and are even able to get access money through different grants and funding opportunities that are not able to be achieved if it was managed by the Indian Health Services because of the bureaucracy of the Indian Health Service. So it's become very successful. I've been a member of the board of directors since 2016. And after the tribe took over the management of the hospital, they have expanded the number of specialty care, and their revenue and budget has increased threefold since they took over. So it just shows that there's a lot of success in tribes taking over the care and management of their hospitals. And here's just a quick blurry photo of myself and some of the members of a board for the San Carlos Apache Healthcare Corporation. Again, it's managed now by the tribe. They run the hospital, make major decisions, and are expanding. And a very successful operation, which more tribes are now beginning to do in managing their own healthcare services. Now I'm going to end up just talking about caring for Native American people, because as we understand how the system works, a lot of you will be involved in the care of Native American people, and I think it's just important to highlight some areas that I think important to think about. Some of you may already have or part of Indian tribes or have affiliation with Indian tribes or work with Indian tribes, so I'm sure some of this is very familiar to you. But you know, what we learn in med school or any other professional healthcare training is just the knowledge of medicine, which is basically the tip of the iceberg in knowing the knowledge, having the knowledge of the individual, the community, and the culture of the people that we serve. This is my people, the Yaqui Ueme on the left-hand side and the Apache Ende on the right-hand side. These are just photos I take from some very sacred ceremonies that are conducted. On the left hand is a deer dancer who dances at different ceremonies to bring the blessings to the Yaqui people. On the right-hand side is the crown dancer who's dancing at a sunrise dance in Apache at the coming of age of a young lady as she enters her young womanhood journey. Again, Indian people really believe strongly in the sense of ceremonies to connect them to the land, to the changes in their life, to the importance of their culture, to the sustainability of their language, which is really good to see now, because as we kind of reviewed historical trauma, the government made a lot of efforts to try to take away this culture, but it's starting to be revived again through the different practices and ceremonies of our people. This is a photo of a mural in my community of Guadalupe. And the reason I show this is because a lot of our Indian communities are very diverse. Through the influence of Christianity and Western civilization, you know, one Indian community can differ from another in the terms of how it's assimilated, how it's traditional, and how the different languages that are spoken. So as we interact with different Indian communities, we just have to keep in mind that Indian community can also be very diverse. Now, there are certain cultural values that reflect and how it aligns along with healthcare. And I sort of picked these 4 different ones because I felt that these were really critical in understanding how Indian people relate to the land, to each other, and to the world around them. First of all, spirituality is sort of the foundation of Indian people and the connection to the land and to the universe. We're out here in, I was going to share with you that my wife and I, my granddaughter, we took a small vacation to Rocky Point here in Mexico, which is a small resort. And we were out in the hot tub last night, and beautiful stars you could see. And my wife was teaching our young granddaughter, she's from Pine Ridge, South Dakota. My wife is Lakota, teaching her about their spiritual connection to the stars, to the universe, and to the Milky Way, teaching our young granddaughter so she can understand that sense of spirituality in her life. Relationships, we feel as Indigenous people, we're all are related. You know, our family extends beyond bloodlines. You know, it extends to accepting each other as aunties and uncles and cousins, because we're all related in some way and beyond just the bloodline, but we relate as Indigenous people, and we extend the relationship to all our Indigenous people across our country and across the world. Humility, respect, generosity, and courage are part of the Indian people's life. And again, these were types of attitudes and values that we continue to embrace in Indian communities. And again, ceremony. Ceremony is very much part of our life. There's many different types of ceremonies, some very sacred, some more social ceremonies, but it's all a way to reflect on how we continue to practice our culture and our values and our belief systems. On the left-hand side is an older picture of a sweat lodge. It's going to take place. And of course, the picture on the right, many of you are familiar with the smudging, in order to be able to take away the bad energy and improve the energy around us. This is a Plains Indian healing ceremony that you can kind of see, where we have the Indian healer, hands on the patient, and then the families around offering their prayers in order for the wellness of this person. And this, I think, is important to understand, is that it's all about family. You know, family are part of the healing process for Indian people. Their prayers and their support is important to the healing. The healer himself is looked upon only as a vessel of healing. The healing comes from a higher power, which is embraced within the medicine person and is then given to the patient who is in need of that care. Things have not changed very much. This is a photo I took of our healing ceremony in 1998. Basically the same type of participants. We've got the healer, the patient kneeling, the laying on of hands, the prayers, and the support of the family. And this continues even to this day. A lot of your patients and clients you might see might have already gone a healing. Always important to ask, whether they participate in healing. And most of our people are more than happy to share their experiences with you about the healing process. Many times they don't say anything because they're afraid that they might be not recognized for that. And just to sort of reflect, a lot of things contribute to lower health status among Native Americans, lower educational levels, poverty, discrimination, and also the inadequacy of funding for the Indian Health Service. And this contributes to what we also see today in terms of disparities and what we see in the social determinants of health. Just quickly, just to show that, as much as 36% of Native people kids drop out of high school. Only 65% of Native people graduate from high school, 9% college degree. Higher numbers we see in areas where there's a major lack of understanding of Native American culture. Mean household income for those living on reservations, $11,000 to $29,000. And approximately 20% of Native households make less than $5,000 annually. And this is just important to know, because as people come through your doors, we have to also take into consideration the environment and the background that they live to give context to the kind of care that we need to provide, or the kind of referrals that we need to do. Discrimination continues today, unfortunately, and it impacts cultural beliefs, cultural differences in health belief. Sometimes people don't understand the way Indian people think or believe. There's been assumptions about the cultural and biological inferiority of Native people. The term the drunken Indian even continues today. I first heard this term, the drunken Indian, when I was at ASU in my undergraduate work. We're talking about Indian healthcare, and I heard some kids talking behind me, talking about the drunken Indian. And unfortunately, this is still type of discrimination that continues to be part of today's world. And so we just have to be careful that racism, that doesn't continue in our practice, in our communication with Indian people or any other minority people. So this is the evolution of Indian healthcare. Indian people relied on their healers, they relied on the government, the military. Public health service comes in to enhance that care. And then now, of course, we have a lot of our own people becoming physicians, providers, healthcare providers, to help to begin to come back again into being part of the healthcare that we provide to Indian people. There's some perceptions in Native healthcare that we might need to just think about. There's cultural taboos and traditional beliefs that sometimes evil energy might cause a disease. Surgical intervention might make the disease angry. A patient once told me this when we were operating for ovarian cancer. And maybe the disease is trying to tell the person something about their life. The disease is not just a symptom, but a messenger of that person's life. Addressing patients' concern, it's always important to talk about their cultural beliefs, engage the family, be open to maybe how the patient might want a traditional healer or a ceremony during their hospitalization. Important to develop trust with the medical team, the healthcare team, and maybe have a person of Indigenous descent to be part of the medical team. And also this kind of helps to develop a cultural connection with the medical team. Caring for the patient basically, and I think this would be for any patient, to just understand their beliefs on health and healing. I always encourage providers to learn the patient's language in terms of greeting in their language. It always, because words express good energy. Engage traditional healers when possible. Allow visitation of family members if possible. I know COVID made an impact on that. Speak always and communicate with good positive words, because negative words have a negative energy that the patient might take. It might kind of impact his mental state. Be aware of your body language. Allow for prayer and ceremony if possible. Sometimes a patient might have a medallion or something at their bedside that's important for them in their belief of healing. Be fluid with Indian time, with medication, meal delivery. A lot of our traditional people don't operate from the clock. They just go with whatever needs to happen. And I always explain the purposes of lines and IV bags to sort of take away that anxiety. The importance of relationships is critically important. Again, understanding the family and understanding the patient. This is a quote by Cherokee Chief Wilma Mankiller, that her doctor did not know how to heal an illness, only how to cut it out. More so to herself, she added, the doctor did not know my clan, my family, my history. How could the doctor know how to heal me? And this is the way Indian people think. It's really developing a trust with a provider, a relationship that's human, not so much based on credentials or training, but a relationship where the patient trusts that person as a human being that has the best intents for that person and their family. So with that, I say ahi'ia, thank you, in Apache. This is a photo of a sunrise over the Apache land in Arizona. The poppies are in bloom. Sunrise is always important to Indian people as the beginning of a new day, a new journey. And prayers are always offered to the sunrise every morning in order to prepare for the day and to receive the good energy for that day. So with that, I'll just end here. I'll stop my sharing, and we'll go back to any questions, comments, or insights.
Dr. Molina, thanks so much for the great presentation. We had a number of questions come in via the chat and within the Q&A, and so I'm just going to start from the top and start working our way down. We got one question from William Weiss. What % of the dollars paid by the government directly benefits patients? And how does this compare to healthcare utilizing third-party payers?
Yeah, most of the money that's comes from the Indian Health Service, which again depends on the facility. Again, the IHS funds anywhere from 35 to 49% of the money that it's used for Indian healthcare. Now that money goes to two different areas, mostly for staffing. Staffing is a big issue in Indian country, and most of that money tries to go to staffing. Staffing is like a rotating door because Indian Health Service doesn't pay quite the amount that most providers would expect to be paid. It's at the government rate. The second priority is facilities and equipment. A lot of aging facilities are still out there that needs to be replaced. Phoenix Indian Medical Center is already 51 years old and has yet to be replaced and upgraded and still waiting for money. It's had to close its late labor and delivery for a year and a half. And it was unfortunate, again, because of funding. The other, over 50% of, well, I would have to say about 30 to 40% of the rest of the funding is from Medicare and Medicaid. And I think the government relies on this funding in order not to meet its trust responsibility for full funding of the Indian Health Service. And then the other 10% up to 15% might come from private insurance. Private insurance is still a billable service with Indian Health Service. Like I myself have private insurance and I go to the Indian Health Service facility, and the Indian Health Service facility is able to bill my private insurance, and that money comes back to the hospital. So a lot of us, even though we have private insurance, we continue to go to Indian Health Services in order for that money to be coming back to the facility. Did I answer that, or was there a second part to that question?
I don't know if you're able to do the second part. So the second part of the question was, how does this compare for healthcare utilizing third-party payers?
Yeah, I mean, what's happened is because of the underfunding of the Indian Health Service, Indian Health Service facilities have had to boost up their third-party reimbursement in order to make up the difference. And I think that's where the sort of balance is at. I think Congress wants the Indian people to do third-party reimbursement like Medicare, Medicaid, and third-party in order to make up for the difference. But that might come to a change because there's always lobbying that's going on in order to have the government fully fund the Indian Health Service. Yeah.
Thanks, Dr. Molina. One question here from Josh Murphy. How does the government defender explain that it does not provide 100% of IHS funding needs?
One of the biggest concerns from Congress is that the Indian Health Service is not providing good oversight for the funding. In other words, they're mismanaging. They're not providing the right kind of care at the right time. So it always comes back to that argument, is that they're not being efficient. And if efficiency always comes up as sort of the argument from Congress as to why it's not being fully funded. The other thing is that because Medicare and Medicaid provides a big substantial part of the funding, then the government is saying, well, you can always go back and bill Medicare and Medicaid in order to provide for the difference that you need. So that's basically the back and forth argument that goes on every year.
That makes sense to me. Sure, in another presentation, I heard that the MMB is not innocent in all of this in terms of advocating for what you just talked about in terms of efficiency, right? Another question here from Trudy Jackson. Is common law marriage honored in IHS for same-sex couples as it is usually acknowledged with cisgender couples? Question one. Is a marriage license for same-sex couples honored if the couple is married in a union with the within the sovereign nation boundaries?
You know, that's unfortunate that's been one of the issues that's been coming up with IHS. With IHS managed facilities like the Phoenix Medical Center, unfortunately, that's an issue of contention. And other facilities like the San Carlos Apache, who is run by the hospital, they're able to develop their own policies and rules around that. So it's going to vary across different sites. You know, if it's a federally managed government hospital, it's going to be a little bit different story than what you'll find on tribal land if they're managing their own hospitals. Yeah.
Great, thank you. We had an anonymous question, and this is a typical ask question or a question that I get commonly. Notice that you're generally using the word Indian instead of other terms such as Native, Indigenous, Native American, etc. Can you speak a little bit about your word choice here?
Yeah, absolutely. The word Indian comes back from a historical sort of a background. It's actually, it's still even used today in federal government documents. In terms of compacts and contracts with Indian people, is still referred to as Indian. That's a federal government terminology. Native American is used by some people, but then some people don't like using it because it brings the word American into it. Native is probably the most commonly used term that's used among the social sort of arenas, if you will. So when we're speaking about government funded programs and government documents and government legislation, the word Indian is used a lot because that's what really is the foundation of a lot of the federal legislation and the documents that run. It depends on which circle you're in. And because I've worked both in the federal government for Indian healthcare, I've worked in the private sector, I've worked with tribally managed. The words Indian, Native American, Native seems to sort of tumble in my head, kind of depending on what I'm trying to sort of bring out. But these are still very much terms that are used today. You know, it kind of depends on the audience that you're with or what you're speaking about, what the subject might be. Yeah.
It's a really good explanation. Thank you. There's two more questions. Do you have any suggestions about what can be done to improve the educational process? I think it's in relation to some of the issues there.
You mean the educational process for Indian people? Or
let's see if we can get a clarification on that. Yes.
Yeah, you know, I think things are moving forward slowly. As I mentioned before, over 70% of Indian people now live in urban areas. So now they're getting to more in the Western way of life, into education, into looking at different careers, opportunities. Universities are becoming more embedded in Indian communities to improve educational opportunities for Indian people. For instance, the University of Arizona in Tucson offers free tuition to the Indian people in Arizona. Again, trying to expand those opportunities. But I think what they're finding is that, at least what I'm finding, is that as we expand more into Western education, we have to be careful to balance our traditional belief systems with the Western lifestyle, because a lot of times they're very much in conflict. And I think a lot of folks who go into the Western educational system outside the reservation are very cognizant of this. There's educational opportunities on the reservations which are more, if you will, understanding of the Indian way of life, if you will, and try to incorporate that into their educational system. But there is movement. I think more of our kids are getting into higher education opportunities.
Thank you, sir. I think we've got time for one last quick question here. You spoke briefly of the historical trauma experience between tribes and the United States government. Yet there was also trauma with health services not discussed. This currently leads to continued mistrust and potential disparities for Native families. What are your thoughts for addressing past events such as forced sterilization of Native American women and the impact that families still have today?
Yeah, unfortunately, the memories of our people are still very real. You know, we're not far away from forced sterilization and understanding what happened then. I think now, as we become into a new age of healthcare, as more tribes are taking over their healthcare systems, right now, almost 70% of tribes manage their own healthcare systems, and that has really made a big impact. A lot of our people are getting more educated in law, and they're becoming part of different organizations and associations that impact the decision making at the government level. We can't undo the history of the past as what's happened, but rather it becomes an opportunity for us to see where our young people who are educated in law, in medicine, and in different areas that make these decisions are going to really make an impact for the future of our kids. You know, it's an unfortunate history. It's something we can't change, but we've learned from. And I think it's really given a stimulus for our young people to move forward and to really make a good future for our families and our children, for our next generations.
All right, we had many good comments and questions today in our chat here. I'm not sure if you had a chance to look at it, but a lot of people just thanking you for the presentation, all the good information. And if you're able to share your slideshow, I think a lot of people would appreciate that. So we can also get that from you.
Sure, I think that'd be.
So I just want to thank you again for taking time from your vacation there to share this wonderful information we have. And I want to thank everyone for joining us today, and hopefully that you guys can complete our quick short survey to provide feedback on the speaker series. if you do have a phone or a device right now, you can use this QR code to get to that survey. And also, if you would like to view any past presentations, I did provide a link in our chat, but also you can find it on our Native American Research Outreach website. So when I send my invitations for these speaking events, I also have a link on my email signature, and also want to bring awareness that our next guest speaker will be with us on October 20th, 2022. And just want to thank you again, Dr. Molina, for your time. That was a really awesome presentation and good conversation.
Well, thank you all. I appreciate it. And again, I appreciate all the great work you're doing for our people. Thank you. Thank you, Karina, and everybody.
Thank you all.